Hello, everyone. My name is Halima Siddiqui, and I'm the executive coordinator here at Health Nexus. So Health Nexus, let me just tell you a little bit about what we do. Health Nexus oversees several provincial initiatives related to FASD. The FASD provincial website, where you can find recent and up-to-date information about what's happening, learn more about resources and tools, and find out services available in your local community. We also allocate subsidies every year to 40 plus support groups for individuals with FASD and their families. And we designed an online training for service providers from various sectors, including healthcare and nursing, education, mental health and addictions, justice and corrections, and community and social work. Before we move on, I just want to explain a couple house rules to you. We will answer questions after the presentation, so please ask them in the Q&A section of the Zoom webinar. And remember, please not use any identifiable information when asking questions. So, before we begin this presentation, I'd like to just start off with a land acknowledgement. We would like to begin by acknowledging the Indigenous peoples of all the lands that we are on today. While we meet today on a virtual platform, let's take a moment to acknowledge the importance of the lands which we each call home. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our own understanding of local Indigenous people and their cultures. From coast to coast, we acknowledge the ancestral and unceded territory of all the Inuit, Métis, and First Nations people that call this land home. Please join me in a moment of reflection to acknowledge the harms and mistakes of the past and to consider how we can each, in our own way, try to move forward in a spirit of reconciliation and collaboration. I'd like to just move forward first and introduce our speakers. First, we have Wanda White. Wanda is a birth parent and social worker providing support and advocacy to individuals and families. Wanda continues to champion FASD through training and peer facilitation. We also have here Karen Huber. Karen has been working as helper and community developer for 30 years. She has experience in assessment, diagnosis, and intervention in the field of fetal alcohol spectrum disorder. She roots her work in the belief that evidence-based FASD education for caregivers, programs, and communities is a key to success. She is the FASD coordinator at Sunbeam Developmental Resource Center, as well as chairing the Ontario FASD Community of Practice. She contributes to projects with FASD1 and sits on the Health Nexus Advisory Group. Thanks to a grant from Health Nexus, she helps to facilitate a support group for birth mothers caring for their children with FASD. We also have with us today Maureen Parks. Maureen Parks, the Fetal Alcohol Spectrum Disorder Coordinator, works at the Norwest Community Health Centers, CHCs, in Thunder Bay, Ontario. Since the program's inception in 2002, Maureen has gained extensive and comprehensive training and experience in working with and providing programming for individuals with FASD. As a program developer and certified Health Canada fetal alcohol spectrum disorder trainer, she has developed a community network of well over 70 FASD resource persons in the Thunder Bay area, representing policing, corrections, child protection agencies, school boards, and other agencies serving clients with FASD. Maureen was instrumental in the development of FASD assessment and diagnostic services, and now coordinates the monthly diagnostic clinic at the Norwest Community Health Center. This program is available to individuals of all ages living in Thunder Bay and the district. And with that, I'd like to pass on the baton to our speakers.
Thank you, everyone, for joining us today. So the three of us are going to present some information on supporting parents and especially birth parents who have identified FASD in their family. So really, we came together because we identified a need in the community regarding this population. I myself am a birth parent and found that in my time in the community, while there's certainly been a lot of change in the context of creating awareness and supporting caregivers, although it's been 15 years, it's really felt kind of like a lifetime. And we still have places to go, but certainly we're on the right trajectory. When I first started on our FASD journey 15 years ago, I felt really unsupported in our community, partially due to the lack of awareness of services and supports, but also due to being a young parent and a birth parent. The misinformation and stigma that was around really made it challenging to ever want to disclose my position as well. There were support groups that existed in our community at that time, and although they weren't exclusive of birth parents, the primary people attending were caregivers, so they may have been kin or adoptive parents. And often, as support groups do, we come together to share our experiences, and some of those experiences are challenging. And some of the language that was used towards birth parents was very harmful for me. And so I didn't go back. I didn't go back. I didn't feel like I fit in. I didn't feel like I fit in anywhere. So it was a really challenging time to be able to see how I could also get those same supports and still have a place to vent my challenges and my frustrations in a safe place. And so sometimes I would speak to other parents, but I still wouldn't disclose that information. I would still talk more about facts and things like that, and not really the underlying challenges that I may have been experiencing. And so, I certainly don't hold uh, any grudges to people I've experienced in support groups, because absolutely I don't think that anyone was acutely understanding that there was an impact on me. And as I said at the time, I was also not in a position where I was going to be able to feel comfortable advocating for myself either. And so I think that was a big part of why we've identified a need in the communities and larger communities to be able to support birth parents.
So when we came together as a group to develop the support group for birth moms caring for their children with FASD, we understood that we needed to make sure we were identifying and taking into account the language that we use. And we need to understand that birth parents really do face particularly high rates of stigma, and the language we use can really challenge those stereotypes about people with FASD, but also promote compassion for women who drank during their pregnancies for whatever reason that might be, and also help others see people with FASD as more than just a disability. And we know that women drink for a number of reasons during their pregnancy, including not knowing they're pregnant, lack of information about the harms of using alcohol during pregnancy. Some partners may encourage alcohol use while pregnant, but the language that we use can help women feel safe and ask questions about alcohol use during their pregnancy. So if we use inclusive language, they are more likely to be able to come forward and have conversations with us about their use. I think to the second point there around FASD not being described as being caused by or the result of, it really oversimplifies an issue that's really complex, and it removes the context of a woman's life that is defining the issue as sort of a single easy choice that you just should not have drank. And then in turn, it really erodes the public's like understanding and compassion of women, and understanding the complexities of why women use alcohol during pregnancy. And then the third point, I think we've all heard, if you're in the field of FASD, that we no longer talk about FASD being 100% preventable. And although FASD can't be considered completely preventable, we need to remember that having full, comprehensive, accessible services and systems to support families, many of those alcohol-exposed pregnancies can be prevented. But we also know wherever there's alcohol, there will be FASD, and we need to keep in mind also that half of pregnancies are unplanned, and there's many factors that affect pregnancy or prenatal alcohol exposure. And then we also need to remember around the prevention piece that using the language, using the prevention language, which we are going to talk about, it can also be stigmatizing for individuals with FASD and birth moms, because if we just solely focus on that prevention message, we can stigmatize those women just by not understanding the complexities around prenatal alcohol exposure and alcohol use during pregnancy. So we can go to the next slide. The other thing we need to consider when we are working with birth parents is using gender inclusive language and ensuring that our language is inclusive to avoid alienating anyone. And I think best practice is to always consult with people directly with lived experience about what language is appropriate and respectful for them. And not all individuals who give birth to a child with FASD will identify as a woman. So those interactions with those who are pregnant, it's important to ask about how they identify, what their gender is, and respectfully refer to them using their pronouns. And then at the same time, it's important for some women to be referred to as mothers. We know in the Indigenous communities that mother and mothering really have important roles, and it's really important to use those terms as well. And the next slide. So when we were reviewing the research for this presentation, we reached out to the folks at CanFASD that work both in prevention but also in support, and we're able to gather some research around what does it say about birth mothers? How do we support? What do we know? What about the prevalence? So this information comes from the study from Popova of 2020, and you might be familiar with that because it's the research that was done by her and colleagues on the prevalence rates in Canada. So this data came from that sample, a sample of that study. So previous studies on the characteristics of birth moms of children with FASD have been published, many focused on sort of clinic-based, low-income, high-risk populations, whereas this study is population-based. So it's a general sample of the population. And the birth mothers were interviewed. The data was collected on demographics such as where they live, what was their pregnancy history like, their nutrition, what was their relationship with drugs and alcohol before understanding that they were pregnant. So really what came out of that was that the mothers of children with FASD really didn't significantly differ from the mothers of the children in a control group. So when it came to age, ethnicity, marital status, employment, at the time of pregnancy, the groups didn't differ. And none of the moms with children diagnosed with an FASD or the moms that didn't have a child with an FASD in the control group, those moms didn't report having problematic drinking habits ever, or having ever sought help or treatment for that alcohol. So prior to the recognition of the pregnancy as well, there was no significant differences between the moms of the control group and the moms of the children with FASD. So Maureen is also going to talk a little bit about what that means, and sort of the take-home message is about what we perceive a birth mother of a child with an FASD might be, coming from a lower socioeconomic standing, et cetera. But what the information and then this study actually told us is that there isn't much difference between the group of women who has a child with an FASD and the control group.
Thank you, Karen. Hi, everyone. I just want you to know I'm super happy to be here today. And I just want to tell you how grateful I am to be presenting with my esteemed colleagues, Wanda and Karen. So here's some different research that was done back in 2000, and it was spanned over 5 years, and it was done by Dr. Susan Astley. Now, this is going to be slightly different than to what Karen was speaking to, but this was very controlled, and this is with it was comprehensive interviews were conducted with 80 women who had given birth to a child with a diagnosis of an FAS. And of course, FAS, we use FASD now. This is the older language from 2000 and in the United States. Now, to document, the interviews were to document their socio-demographics, to reproductive and family planning history, social and healthcare utilization patterns, adverse social experiences, social support network, alcohol use, and treatment history, mental health, and IQ. Now, these high-risk women were diverse in racial, educational, economic backgrounds, and were often victims of abuse and challenged by mental health issues. Now, specifically, it was determined 96% of these 80 birth mothers had 1 to 10 mental health disorders. 95% had been physically or sexually abused during their lifetime. 79% of the of the 80 birth mothers, reported having a birth parent with a substance misuse disorder. So then that begs the question, could any of the birth mothers themselves have an FASD, which speaks to the intergenerational impacts of FASD and intergenerational trauma. Now, despite their harsh profile, psychosocial profile, they demonstrated the ability to overcome their alcohol dependence over time. Now, relative to the women who had not achieved abstinence, the women who had achieved abstinence had significantly higher IQs, higher household incomes, larger, more satisfactory social support networks, were more likely to report a religious affiliation, and were more likely to be receiving mental health treatment for their mental health disorders. The rate of unintended pregnancies and alcohol-exposed pregnancies was substantial. And key barriers to achieving the effective family planning were maternal alcohol and drug use, lack of access to birth control, and lack of support by their partner to use birth control. Primary prevention programs targeted to this population could lead to a measurable reduction in the incidence of FASD, as well as FASD diagnostic clinics can be a catalyst in identifying women at high risk for alcohol-exposed pregnancies. So as Karen mentioned, racism surrounding FASD results in harmful and inaccurate assumptions that FASD is more common amongst First Nations, Inuit, and Métis children. Those who work in child serving systems report that First Nations, Inuit, and Métis children are sent for an FASD assessment more often than non-Indigenous children who present with very similar challenges and support needs. These assumptions are not only harmful, but they are also discriminatory and may lead to misdiagnosis and mismatched supports. Anyone can have an FASD. It is not limited to any racial, ethnic, cultural, or geographic group. It is a disability that is found across all demographics across the world. It is a complex, multifaceted disability and affects people differently. And this is why it is described as a spectrum disorder. Because it is misunderstood, people with FASD are often blamed for their challenges they face in daily living and excluded from the very needed services, supports, and community throughout their lives. The highest prevalence of late pregnancy alcohol consumption reported by mothers who were Caucasian, age 35 or older, and university and college graduates. That's the highest prevalence of late pregnancy alcohol consumption. 19% of mothers reported that their prenatal care provider did not ask whether they were drinking alcoholic beverages. And 30% reported that a healthcare provider did not counsel them about consequences of alcohol use on the child. Reported screening and counseling were least prevalent among mothers who were Caucasian, aged 35 years or older, and college graduates.
Yeah, so I think based on all of that, right, we still know that a lot of misinformation in the community and in society as a whole still exists, which then can perpetuate different types of stigma that are experienced. Stigma often comes from that lack of understanding, usually from inaccurate information. And then any positive potential of those experiencing an FASD are often overshadowed by this negative public perception. So really misinformation concerning safe levels of alcohol consumption in pregnancy and stigma towards women who drink in pregnancy is concerning. The media's portrayal of women's alcohol use in pregnancy often perpetuates narratives of victimhood or shame, where mothers are often seen as irresponsible or immoral. These narratives do not consider the many influences on women's substance use, and they continue to perpetuate misconceptions of which groups of women use alcohol in pregnancy. And as we know, it is non-discriminatory. The discrimination directed towards women who have substance use problems and become pregnant, and the inconsistent messaging around substance use in pregnancy by healthcare providers will deter women from seeking the help they and their children may need and undermines access to proper medical care, which includes the assessment of FASD. We definitely need to recognize our own bias when encountering parents, especially birth mothers, because of really these three levels of stigma. So stigma not only affects individuals, but also the loved ones who support them, including friends and family members. Women often underreport their alcohol use due to fear of judgment, feelings of shame or embarrassment, or fear of services becoming involved, including child welfare. The result of these narratives can cause providers to not ask all women of childbearing age about their substance use and to only ask subpopulations who have been falsely stereotyped. Many women come to believe the negative stereotypes that they are unfit to mother and that these beliefs may be compounded by feelings of guilt or fear as to how their alcohol use has impacted their child's brain and their child's health. These internalized perceptions ultimately negatively affect a mother's feelings about themselves, which can lower self-esteem and confidence in parenting. Moreover, this stigma creates significant barriers to service delivery and accessing supports. So I think overall, what we need to understand in order to address some of the different levels of stigma is just remembering that FASD is not intentional. We know that upwards of over half of pregnancies are unplanned. And one of the key messages I always share is that many people don't start being pregnant until they find out that they're pregnant. And that's often where we may experience some alcohol-exposed pregnancies as well. Often, mental health, trauma, and substance use or addiction may make it challenging to stop alcohol use in a pregnancy. There also continues to be so much misinformation, and really in society, drinking alcohol is normalized and often accepted and celebrated. And we're also seeing, of course, that increasingly women are drinking more frequently and having more on those days that they are drinking as well. So we have the low risk drinking guidelines, and we're seeing across the board in kind of the addiction and mental health space that the overall increases. Many families go without assessment or diagnosis of FASD, and this lack of assessment and awareness affects being able to access what resources may be out there. And that also can be impacted by the misinformation, who's being asked, how are they accessing these supports? And FASD does not discriminate, as we've said. There are people living with FASD from in all groups of society, not just in the vulnerable populations. And really that simplification of FASD as preventable disability can really be harmful, especially towards birth parents, which just continues to further stigmatize and marginalize those people who really need access to the supports and services. So really, when we're thinking about being trauma informed and providing approaches, it's really important to have these 4 key principles. Really relational, judgment-free, supportive, emotionally safe, culturally responsive, coming from a heart view. All of these supports can be identified, or all of these descriptors are ways that we can be trauma informed. And the biggest part of identifying how we can apply those is to recognize our own biases when we are providing effective care to others. In a scoping review by Melody Morton Neomaya, who did a report about supporting pregnant and parenting women who use alcohol during pregnancy, the report recommended trauma-informed approaches and practices, essentially stating that relationship and trust are needed above all else when working with parents. A relational approach is designed to be reparative of past negative, overwhelming, unsafe relationships to provide an opportunity to build trust and connection. In addition, linking trauma-informed practices to cultural safety, especially where power imbalances exist, which can be most relevant for Indigenous peoples and or racialized people who are accessing care within colonial settings. Service providers who are providing care and support need to be aware, reflective, and humble when they're engaging parents.
All right, that's me. So I want you to consider, when you're working with families, whether it's an open adoption, customary care, or kinship, about considering the implications of a birth mother in that relationship. Because not all birth parents are full-time caregivers. And with the increase of open adoptions, often birth mothers are part of the picture. And it's really important that we consider their well-being when we're either going through the assessment and diagnostic process or supporting families. There's many things that we do as, people that deliver service. As one of the provincial FASD workers, I often spend time helping families find prenatal alcohol exposure confirmation from a variety of sources. And one of those sources is interviewing a birth mother. And we have to be considering not just going and asking that question of a birth mother and then leaving the scene. We have to consider what are some of the follow-up supports that mom might need, even despite the fact that she might not be parenting that child full-time. We have a unique opportunity to be able to prevent future alcohol-exposed pregnancies by providing some opportunities around brief intervention, which I'm going to get into in a minute. But, how could a relationship between an adoptive family, kinship family, and the birth mother be impacted by your work? And we have to be really careful that we're not causing harm in situations where there is an opportunity for assessment. And reaching a birth mom just for the sake of confirming alcohol use during pregnancy can be really stigmatizing and really re-traumatizing. So we have to be mindful and careful and use really good clinical judgment around how we do that and the follow-up support that we provide after the fact. And there isn't a lot of information on this. We've had conversations about how can we research the experience of birth mothers who are not caring for their children with an FASD through that assessment and support process, and we really don't have a lot of that. But of course, the recipe for much of this is relationship, and also to do no harm. So when I'm working with birth families, these are the questions that I will ask, whether or not they're caring for their children or they're not caring for their children. So it's just something we need to be very careful about and consider, and also considering the relationship between a birth mother and their child as we go through that assessment piece and that support piece too, is how can we increase the attachment. So we're going to talk about, in the next couple of slides, opportunities for practice-informed supports. And these are the things that, even looking at the literature, but also things that we have done in our practice. And a lot of the information reviewed for this presentation, not surprisingly, like I said before, relationship is the most important ingredient for the support of birth parents. And we looked at research, and one of the studies that came out of New Zealand, actually, on birth mothers, the theme of that study was just a systemic misunderstanding and blame. And it really highlighted the need for everyone, all health and social service providers, to receive non-stigmatizing FASD training. In that study, in the New Zealand study, they also felt that healthcare and education were the systems where moms felt the most misunderstood. So targeting those systems for really good FASD-informed training is key to the success also for birth families. And then the next piece is sort of in a systemic approach is, how do we build, and I know this has been a question on a lot of people's minds lately when I've been in different meetings with those who support people with FASD, is how do we increase our system capacity in screening and identifying who might be living with an FASD? So how do we embed practices within our own communities about asking the question around prenatal alcohol exposure? And how do we create sort of that competence and confidence? And I used to always say we need competence and confidence in this, but we also need consistency. We have to be consistently asking this question across a number of domains, wherever children, youth, and families are actually showing up for supports and services. And we need to build that system capacity to be able to be doing that a little bit better. And not just asking the question of the women who we think might be parenting a child with an FASD. And then there's the whole area of prevention and how, as service providers, can we embed prevention practices into our work. And I know that Health Nexus just recently had Nancy Poole come and talk about prevention and the 4 levels of prevention. And anything that Nancy does is amazing. And she's such a great researcher. So going back and viewing that webinar, I would highly recommend. But when we're thinking about what we can do as support people, is how do we provide opportunities for women and girls of childbearing years to ask questions about alcohol use, to ask questions about their health and contraception and safe sex practices, and even other concerns like substance use and just their general well-being. Because I think during conversations, we can be encouraging girls and women to think about their alcohol use and identify how they can leverage their community and their supports to increase their health. Because as support people, there's also so many opportunities for us to provide brief intervention. And when we're supporting birth mothers through the process of assessment or support, we can always have conversations about the harms of risky patterns of substance use, and also looking at what underlies some of those risky use of substances, right? Are they the social determinants of health? Is it intimate partner violence? Is it inequity? Is it mental health? Like, how can we support those moms when we're doing that work? So, and those brief interventions, they can be one-time conversations, they can be informal, they can be formal, they can be structured, they can be long, they can be short. And often they're not one-time events. They're often conversations we have over a period of time with the moms that we're working with. And they also, of course, they need to be trauma-informed and culturally safe. And there's two documents that I would suggest looking at, and one is the work of Nancy Poole, and it's the 10 fundamental components of FASD prevention. And then there's also another document on the CanFASD website that talks about brief intervention for girls and women who identify as Indigenous. So those are both two really great resources I would recommend taking a peek at.
Hi, thank you. I've had the opportunity to work in the area. It's about 60% of the work I do, assessment and diagnosis. And I cannot tell you, with everything that Karen is saying in respect to this, the last slide, the importance of that information. One of the things I've come to learn is one of the most important things, again, is about relationship. And it's about being very aware and cognizant of not bringing harm to the birth mom. And no matter what, every mother who has a child with an FASD will face or experience discrimination, stigmatization, and judgment. And it seems to be, unfortunately, very common, a common experience for birth mothers. And I'm so grateful that we can have this conversation today. Now, one of the things that, one of the challenges when we're working with assessment and diagnosis and diagnostic clinics is that the initial referral, and it's about who is asking the question. And, and so it's about that actually becomes a barrier, can be a barrier to having people come to our diagnostic clinic. So referral for FASD assessment, FASD diagnosis and prevention are significantly challenged by stigma. So first, diagnostic assessment requires confirmation of prenatal alcohol consumption and can be difficult to obtain if birth mom feels shame or fear of judgment and or child removal. And it's not unusual to hear that question asked, will my child be removed if I'm diagnosed with an FASD? And so we could never do the work we do if we had judgment. We could never do. We have judgment doesn't even fit. It cannot be in our vocabulary when we're working, in the field of FASD. Second, if children are in foster or adoptive care, attempts are often made. We have to make attempts, right, to find the birth mom, which sometimes can be very difficult if mom is not in the same community or we're unaware of where she might be living. And so talking to the mother, just like Karen was saying, talking to the mother just for the sake of confirming alcohol use during pregnancy can be difficult. And it's a hard conversation, especially if you don't have that relationship with the mom. It's highly stigmatizing. and again, re-traumatizing. And lastly, for children and youth living with an FASD diagnosis, it can be difficult to make sense of why their birth mother consumed alcohol during pregnancy. But one of the things we do know, and I've seen repeatedly over and over and over, and we've done numerous, I mean, we've been working with assessment and diagnosis for several years now, as I've said, and I have never heard a child said that they were mad or they did not like their mother. And it's, if anything, I hear the individuals to be very compassionate towards their mothers and understanding towards their mothers. And that is a beautiful thing. So, but that does pose a barrier because sometimes it's hard to explain to children, right? Depending obviously on the age, about mom's alcohol use during pregnancy and the whole disability of FASD. And so, yeah, that's my thing about assessment and diagnosis. Next slide for Wanda.
So a key piece that we've really talked about on the next slide is regarding like parenting supports and ways to encounter and support parents in a variety of ways. We've talked a lot about relationship and we've talked a lot about non-judgmental, non-stigmatizing. I will also say that we are by nature, humans by nature are judgmental folks. And so often it's about really just identifying those biases and judgments that we may be experiencing. And that with FASD, it's often caused by, again, that societal and cultural impacts about how we perceive FASD and how we perceive birth mothers. Because that may be the only experience that we have is those societal perceptions. So while I think it's more important to see where we are and identify our own biases and our own social location and our own information when we're working with parents. So certainly there's lots of ways that parents and birth mothers can be supported. Really maintaining and strengthening attachment is a key focus. So home stability is associated with numerous positive outcomes for individuals with an FASD, including a reduction in the severity of behavior or social problems. It can also impact the frequency to which adverse outcomes or secondary disabilities may occur or be as impactful. Given that individuals with FASD may experience multiple supports or multiple caregivers, assembling a dedicated, educated team to promote healthy home stability has the potential to allow a child to form secure attachments to those people and caregivers in their life. The earlier that interventions can support attachment, the better. As I mentioned, can prevent adverse outcomes and improve overall family functioning. Interventions using kind of a dual attachment and trauma-informed lens have the potential to have positive impacts for children and families. And so while we recognize the earlier the better, we also know that attachment intervention can occur at any stage as well. So for example, there is something called child-parent psychotherapy, which is a relationship-focused, reflective, and developmentally attuned model of psychotherapy for children with histories of trauma, maltreatment, and associated problems with behavior, self-regulation, and post-traumatic stress. With regards to outcomes, they're really hoping to create safety in parent-child relationships and their environments, expand positive parental responsiveness and attunement, and promote parental capacity to balance their own as a parent as well as their child's needs. And that both people who are engaging in this form of therapy are beginning to identify and challenge their own perceptions of the other person as well. So both the parent-child in that relationship. Attachment informed treatments, as I mentioned, can happen at any stage. And it's really kind of understanding that even attachment in adolescence can help to predict adaptive functioning. Because of this, researchers are really trying to develop interventions to promote security between adolescents and caregivers, such as a program called the Connect program. This attachment program is intended to increase caregivers' understanding of the behaviors they are seeing and make connections to underlying attachment and different circumstances that may be contributing to the behaviors, which inevitably develop trauma-informed parenting skills. Preliminary evaluation of the Connect program has produced promising results, including reduction in caregiver report of oppositional, aggressive, and antisocial behavior, as well as decreases in anxiety and depression. It's also really important for parents to build a circle of support with those who understand FASD. So building this circle or village is really imperative because the weight of parenting can often be overwhelming. Individuals with FASD will experience some degree of challenges in their daily living, whether they need support with motor skills, physical health, learning, memory, attention, communication, emotion regulation, and social skills in order to reach their full potential. And this may include a mix of personal and professional connections. So really identifying who in that circle or in that village is going to be a support. And part of that can be encouraging connections with other birth mothers. When that happens, there is an innate sense of connection that reduces isolation, and just to know that someone else out there has kind of experienced what you've experienced can make a difference in the journey of FASD. Grief and loss is also a key thing to kind of be aware of. While it's of course normal for caregivers to have feelings of grief and loss along a journey with FASD, this can be more impactful for birth mothers as there's another layer of challenges to work through, which may include feelings of guilt and shame, whether they've been internalized or whether they're kind of external through society. The feeling of loss for what could have been or what has happened can be really overwhelming and provide additional speed bumps kind of on the journey and need to be addressed. It's really important for caregivers and for health professionals to recognize that this exists and really be able to provide supports as needed, because a mother's or parent's own physical and emotional health is crucial to them being able to provide their own parenting that comes from a healthy attachment focused place. When we're able to assist in shifting from kind of a negative, experiencing the negative challenges and the grief and loss into a more productive and positive path, then the outcomes are just like much greater. Next slide, please. So that's why we all, that's a lot of information, but that's all why we came together, the three of us, to determine how can we be able to address and identify some of the needs that are experienced by birth mothers. So what we really wanted to do was create a space to discuss the unique challenges and opportunities to being a birth parent, with the hopes of decreasing stigma and increasing community. And really that connection piece, I think, is the most underlying tone of everything that we're doing, but hopefully our greatest outcome. So we have a number of weeks. So our current group is 6. I call it weeks, but it's one session per month, where we come together virtually from all over Ontario. And we have kind of these 6 key areas that we identified as being the most important to address. So first of all, providing kind of an FASD 101, recognizing that depending on a parent's connection to the FASD community, to their support workers, to who they've heard about FASD from, the knowledge is vast. It's a spectrum of people understanding. So we wanted to be sure that we provided some consistent messaging, so that would tailor us through the weeks as well. We also talk, of course, about stigma, both the internalized stigma, cultural stigma, the different levels, and how that impacts each person differently as well. As we mentioned, building a village and creating a support network is crucial. We look at identifying both personal and professional connections for parents to have. And you know, I'm really pleased to actually, you know, say that all of our birth moms in the group actually committed to making a step to increase their village, and they all actually did. And that was really the like such a great warm moment that we had to be able to say, wow, like this is actually starting to make a difference. We also talked about disclosure and advocacy, and that may mean disclosure to your child, to your family, whether it's more formal in meetings and or more informal. Sometimes talking about how to do reactive disclosure when you're in certain environments and situations, and how to work through that. And then advocating for your child, for your family, but really advocating for yourself as a parent as well. What do you need? And how does that help you, again, to build your own innate capacity and resilience? We're also going to be talking, as we've mentioned, about grief and loss, the different layers that women experience. You know, being a parent, being a parent to a child with special needs, being a birth parent to a child with an FASD, and really unpacking some of those layers and being able to address the supports that may be needed in order to, you know, reduce the internalized feelings, and be able to access supports and advocate for yourself as well. And last but not least, just as important, and it's kind of been addressed throughout our group, is thinking about self-care, and thinking about what, again, you may need as a parent in order to be in the best possible space that you can be. You know, we do best. We only can do what we can do with what we have, and if we can increase those feelings of confidence, and by taking care of yourself, then that's going to be one of our goals as well. So we're planning, of course, to use pre and post measures. We did pre-screening as part of the group. One of our key objectives is that connection. And even, you know, it may seem small, but one of our questions is, have you ever met another birth mother? And really being able to address that, because it isn't that common, and building, again, that sense of community and reducing the isolation. One of the key challenges that we've experienced is identifying that we have limited participants. So this was put out to multiple communities, multiple regions, multiple workers and service providers. We were hoping for 15, and we're sitting just under half of that. And we know that this limited participation in our group is not representative of the greater communities. And so part of what we're going to be doing after the group is ending, we're still in the middle of it right now, is to determine what are the continued barriers maybe to engaging with the group. Again, is it that people aren't having the conversations? Is it that birth parents are not comfortable engaging with a group? And so really being able to tease some of that out, because we recognize that this hopefully is being really helpful, and we want to be able to continue reaching more birth moms along the way.
Great. Thank you so much, everyone. Thank you to our speakers for this absolutely wonderful presentation today, and for our participants for listening from across the province. Thank you for providing your questions in the Q&A. They were, I think, very invigorating questions. So yeah, I just want to sign off and say take care, everyone, and stay tuned for more webinars by Health Nexus.